interesting and pressing topic about driving affordability on a highly specialized segment of our Medicare population that is usually catered to by a special needs plan. We have Sri. I guess I'd like to maybe start by introducing myself. My name is Kangana Mehta. I'm a Senior Director of Growth Strategy at Innovaccer. And we have two panelists today. One is Sri Bharadwaj, who is the Chief Operating and Information Officer at Longevity Health Plan. And then we also have Gaurav Mehta, who's a partner at PwC. Before we kick off, I'd like to invite Sri and Gaurav to introduce yourselves and talk a little bit about your organizations and what they do. Sri?
Thank you, Kangana. Really appreciate and great topic to talk about. Longevity Health Plan is a health plan that services most of our members are institutional special needs members. They are in the nursing home greater than 90 days or proceed to be in the nursing home greater than 90 days. So it's a very specialized, high intense post-acute population that we serve in several states. We have the opportunity to partner with a couple of other larger health plans in the nation to serve their population as a dedicated risk provider as well.
Great. Gaurav?
Thanks, Kangana. Very excited to be here today. Gaurav Mehta, partner at PwC in our healthcare practice. This is a very interesting topic that's near and dear to me personally and to our firm. I think affordability is probably in the top 3 items for any C-suite agenda these days. We're extensively working with payers and providers across the country on how do we make healthcare more affordable, right, for our consumers, for our clinicians, for our providers, and how do we do that in a collective way where we bring payers, providers, and innovative organizations together. And we've been working closely with Sri and others at Longevity on some aspects there as well. So very excited to share some of that today and look forward to the conversation.
Thank you. Awesome. So let's get started. And thank you for mentioning PwC. One of my favorite reports on the industry is the PwC report on the medical cost trend that addresses, some of the specific elements of how cost will trend year over year. And what was interesting about the 2024 projections is the fact that the increase is expected to be actually greater than the previous years. The report really suggests that some of the key sort of inflators of the cost would be inflationary pressures that the economy is dealing with, but would be particularly acute when it comes to healthcare. And some of the continuing sort of double-digit trends that are seen in regards to drugs. And I think this is really interesting because it sets the stage for, some of the cost pressures that you talked about and really presents affordability as the greatest challenge that we all need to come together and, try to solve. I wanted to sort of invite Gaurav, you to maybe speak to these trends that the report is talking about as you revisit sort of the operational and just strategies in general to address these cost pressures.
Yeah, happy to, Kangana, and maybe just to throw out a little bit more data for folks from the report, and this report's available online for those that want to see it. But we're seeing both labor and non-labor costs go up in the healthcare ecosystem, right? We're all acutely aware of the clinician staff shortage that exists in the ecosystem today. I think we're projecting a shortage of 60,000 nurses by 2030. And so we don't expect, the cost associated with clinicians, with clinical staffing to come down anytime soon, right? So in the last 3 years alone, since COVID, we've seen, clinical costs go up between 20 to 40%, depending on the organization and depending on the specific market you look at. So that's significant. And along with that, to Kangna's point, inflation has driven the costs up for some of the non-labor costs as well, right? So overall, there's lots of challenges. Obviously, I think we collectively as an industry have made some progress in working on some of the deflators of costs as well, right? So obviously we're all aware of, shifting sites of care, right? Care's moving into the home, we're doing more procedures at ambulatory surgery centers and so on and so forth. We've seen, retailization of care, with the CVSs and Walmarts of the world moving into care delivery. So we collectively as an industry have made some progress in some of those deflators of cost, particularly shifting sites of care. But there's more room for us, right, for all of us to do a little more. And none of the levers here that you see on the page are new, right? We've talked about value-based care, care management, and data analytics for over a decade, if not more. But I think what's changed meaningfully now is there's a higher level of integration between the delivery of care as well as the financing of care, right? Traditionally, going back 10 years, we had some pretty stringent silos between payers and providers, and some of the relationships were more transactional, right? But now we're seeing increasingly, payers partner more closely with providers, providers partnering more closely with payers, and truly trying to align incentives so that the actual delivery of care is truly integrated with the financing of care. And I know, Sri and others at Longevity have been doing things that truly bring the delivery of care and financing of care together, which aligns incentives, which aligns data, which aligns technology for actually all of us to make more meaningful progress on things like value-based care, things like care management, things like advanced analytics, by getting more comprehensive views of patients, by getting more comprehensive views of clinical care pathways. So lots of exciting things happening in the ecosystem, but happy to dive in more.
Yeah, and Sri, I'd love your view, because these cost pressures are obviously felt across the industry, but you're managing a highly specialized population. So would love to get a sense of, how these things are manifesting in that population in particular. And as you think about, folks with really high need and therefore high model of touch, and when it comes to care delivery.
To talk about Longevity, right? We are a clinical services organization in the first place. Right? We care for Medicare beneficiaries, who reside in institutional care level, senior level settings. We have our own Medicare Advantage institutional special needs plans, as well as in partnership with national health insurers, both sides. In both cases, our clinicians and care teams we actually walk into the nursing homes and provide comprehensive patient-centered care for those senior living residents with a level of full range of medical, social, economical, emotional needs, through a value-based model. That's our philosophy, and that's our understanding of what we need to do to get the market in a way that makes sense. We also have, in some cases, added targeted supplemental benefits, which, there is something for that unique, fragile population, such as a music therapy program, stuff like that. On the other hand side, we closely collaborate with skilled nursing facilities, because they are the people who have the data in some respects for us to look at and do evaluation for our members. In order to do all this, right, we know we are what we call a payer and a provider. A payer in terms of having to support those members with the CMS Medicare contract, and a provider of services to make sure that we can get this information to the underserved cohorts and then deliver value-based care. In order to do this, right, we are very uniquely positioned, to actually tell you the truth, to break down these silos. Typically in organizations, you have the provider organization, the payer organization, they're both trying to figure out how to get the data and so on. In our case, we can actually utilize and provide a 360-degree view of the individuals and populations, both just for us, as well as our skilled nursing facilities. So they look forward to us providing the care, but also providing the value that is delivering better enhanced care for that member, for that specific condition in that specific environment. So it's a little bit different, and that's how we bring all the three together. In order to bring all the three together, we get data. The data comes from the silos that we break down. We pull that data, we create the individual view, deliver the view to that clinician at the doorstep, at the bedside, so they can take care of the patient appropriately.
Yep. Thank you, Sri. I think one of the things you mentioned that really bears some discussion is, what is a special needs plan, and how they're different from a traditional Medicare Advantage plan, and why they were really even created and are, sort of one of the fastest growing segments of Medicare Advantage in and of itself. Special needs plans are of different flavors because the idea is that this population is high need and has a lot of need that needs to be really sort of targeted towards them. One of those plans is called the dual special needs plan, which is really catered towards a population that is Medicare and Medicaid eligible. We have the C-SNP plans that are catered towards chronic condition and longevity, as you mentioned, which is an institutionalized special needs plan, which is really towards population that tends to be in an institutionalized setting. One of the things that I think is really interesting in the special needs plan, compliance requirement is the model of care. Where you have to sort of really prove and design your operations towards addressing the specific need. And I think this is where I particularly feel that this is where the value-based care is really inherent in design, because you have to really kind of make sure that you're addressing the need of this population. Some of the interesting trends that we're seeing in regards to I-SNPs in particular is that they are increasingly provider-led. I think, Sri, you mentioned a little bit about how you're working with providers and you are taking delegation with some of the larger payers, but I'd love to get a sense of what you make of this data. We know that SNPs in general are one of the fastest growing segment within Medicare Advantage in and of itself, but what do you make of the fact that I-SNP in particular continues to be so provider-led?
So in order for us to deliver the care, we have to file with the CMS a model of care, right? Which is rather, in a way, really unique from that population perspective. When we file the model of care, we identify what is it that we need to do to get that, appropriate information out to the clinician. So in the model of care, we talk about the health risk assessment that we execute. Then we drive the individual plan of care, IPOC, to make sure we can have that conversation associated with that specific condition that the patient is undergoing. And then we have got the combination of the interdisciplinary care team. It's not just us, it's the PCP, it's the specialist that's taking care of the patient and bringing it all together and delivering that care. Then, of course, there's care transition protocols, right? When many of our members, they transition from a treat-in-place setting in a SNF to a hospital for an event that occurs in their lives, and then they come back from the hospital. So there's a lot of care transition that happens as part of that process. So if you take our typical model of care, you'll go through, what is it that we need to do to create that capability for us to deliver, and what we need to do in terms of getting this all done. Of course, all of this has to be met with, NCQA, CMS guidelines, and all of the approvals that need to get done in order to make it work. So what we do is very specialized. The model of care drives a lot of activity and is a great quality improvement tool with data that brings it together at the hands of the clinician as part of that process. So we have built our own EMR to actually meet the needs of that requirement. And that requirement specifically addresses how we drive that model of care with assessments, with ongoing evaluation of our members between high, medium, and low risk populations, and then the visits that we do for each of those members. So it's fairly complex, but then goes back to driving that cost, driving the understanding of the value that is being delivered by delivering that model of care in a structured manner.
Yep. Gaurav, any views from you? I'm sure you were looking at the industry as a whole. What do you make of the fact that there is so many provider-led I-SNPs, and especially in light of what longevity is kind of addressing?
Yeah, to be honest, the data is not surprising, right? If we think about the population we're talking about here, it's some of the most complex population, in our country. And this population, the demographics, if you look at the data, our population is getting older. We're seeing people with more and more multiple chronic conditions, right? So we expect these segments to continue to increase and continue to grow. And the true care delivery of this population and managing their quality of life, managing their health outcomes requires very complex coordination that Sri described, right, across settings, across transitions, and requires care protocols in place that are actually truly complex to manage across sites of care, across different condition requirements, and so on and so forth. And it's not surprising to see that, a lot of that capability sits within, long-term care organizations, within provider groups. We're actually very well equipped to drive that, right? And so I think it's a small niche but growing segment, and we expect it to continue to grow. And we expect, provider-led iSNPs to continue to grow and play the role that they're playing now, given the complex needs of the population.
Yeah. I fully agree. And because I like to always look at a solution, I think it's a good idea to think about, contextualizing some of the things you mentioned in regards to unique challenges that are, specific to your environment. I think one of the things you mentioned, Sri, is the need for interdisciplinary care and care teams that are, far more, I would say, complex and maybe diverse in regards to what they do on a day-to-day basis. That presents a unique set of challenges. And I suppose, as we say in Innovista, that data fabric where information is actually equally shared across the board. So any thoughts on, what are the specific iSNP challenges? And, I'd love for both of you to opine on it. But, I think that, this is where, in my view, like some of the shift as it's happening in regards to behavior and financial incentives and just in general, sort of being patient-centered delivery of care is really well designed for an iSNP environment.
I mean, if you take the average Medicare beneficiary in an iSNP plan, they're typically frail, vulnerable. They have multiple comorbidity conditions, high blood pressure, heart disease, depression, diabetes, COPD. They have more than, several high-risk medications that are being administered. They probably will need, 5 or more activities of daily living ADLs, bed, mobility, dressing, eating, toiletries, all those kinds of things that are for that population. And, they probably are on some sort of pain and have the, some level of cognitive impairment, right? This is our typical kind of population that's in this group. In many instances, if you look at this, for this complex population, we have to bring in data from several sources, bring in that information in a way that makes sense. What industry has typically done is industry has looked at, solutions that traditionally have provided what I call a recipe for encounters of care, right? That's what industry has always done. I have an encounter, or I have the data, I'm a clinician, I document the data, I send the bill, I'm done. That is the traditional model of how we've seen data being manifested. And of course, that data is great because now I'm a health system. I'm going to harvest the data, try to understand how to treat my population and how to make sure that my population, as they walk in the door, are cared for. And how do I become the best health system providing care, right? Understood. There's a shift in the marketplace. As I said, our model of care is different. We have to have definitely a structured assessment process, not just a standard assessment you go through in a visit, but a ongoing continuous assessment process for that particular member. Secondly, there's individualized plan of care. The individualized plan of care is based on their condition. You can't just say, I'm going to treat you for COPD or CHF while saying, oh, I didn't even know that patient was a diabetic patient. You can't afford to do that. So you need to have that data. Thirdly, you have this comprehensive care team that pulls this together and makes sure that all of the people are talking to each other. Conversations with the PCP, conversations with the clinicians, conversations with the SNF people walking up and down the corridor of the SNF every day, and people who take care of them in their SNF along with their families. So it's a combination of things that needs to occur. Lastly, we have to have care coordination, meaning when the patient gets to the hospital, comes back, what data follows that? Our exact environment today is not focused on bringing the data back and forth. So we have gaps in data that really have to be closed in order to understand what's happening with the patient, number one. That is on the clinical side. We also have gaps on the financial side. We don't know what we are spending on that patient. I shouldn't say spending as a spend, but what is the cost of the care that is being done? Is it really adding value to the patient? Do I just take an ESRD patient, send it to a dialysis center and don't know anything about it? right? That could be possible. And that's perfectly fine. If a dialysis patient sitting at home once in a week or once in 3 weeks keeps going to a dialysis center and getting dialysis done. That's one part of it. But what happens if he has diabetes? What happens if he has COPD? What happens if he has CHF? How do we all bring it all together? What integration we need to get from a data perspective to drive that? That is what we are cracking. That's the nut with what we are cracking. And we have delivered and pulled together an analytics platform with the capabilities that we bring in this data into the environment so we can provide the full picture of that very high sensitive chronic patient to that clinician.
Yeah, absolutely. Gaurav, anything from your view in regards to, what you see,
Yeah,
I guess, differently? Yeah.
Double down a little bit on what Shri said, right? I think two specific areas. One is, Shri, everything you touched on is all about interoperability, right? Interoperability across care settings, across systems to bring the data together. And while, the interoperability mandate from CMS has made, certain strides and, we've taken some steps in the right direction, I think there's long ways to go for us as a healthcare ecosystem to have true interoperability where we're able to bring data together, right? And specifically within the ISNP population, moving between care settings is quite common, right? There's a fair number of hospitalizations given the challenges of some of the population of this population. There's a fair number of urgent care visits. There's a fair number of, even emergency department visits for this population. And so until we have true interoperability, to Shri's point, gathering the life cycle data, the true picture of a patient's end-to-end health data is going to continue to be a challenge. So I think, investments in analytics platform and in interoperability that actually allow us to bring that data back in-house to get a true complete picture, I think are the need of the hour. The second is just expanding beyond true clinical and health requirements of this population, right? These members are often isolated. A lot of them have lost their spouse given where they are in their lifespan, right? So there's isolation issues, there's behavioral health issues. And then there's social drivers issues, like a lot of this population cannot afford some of the things that are required for even, day-to-day necessities and some of the basics, of everyday life, right? Things like access to good food, access to medications, access to certain, daily living things and requirements. And so I think the true sort of bringing in some of the data around what is the true need of a specific individual within this population outside of their true clinical needs, I think we've got long ways to go on making progress in getting some of the social drivers or social determinants of health data. And I think the ability to get some of that through either assessments of their living situation, where they are in these long-term care facilities when they're moving to other settings and coming back in, what does that look like, right? And so I think bringing that social determinants of health data along with interoperability, where we're capturing health data across different settings, I think is still a big challenge in this market. And still, I think we have long ways to go as a healthcare ecosystem to make progress there.
Yeah, absolutely. I think data silos, are usually one of the, I think you mentioned interoperability, a lot of that, is the outcome of the fact that we've traditionally had tremendous silos in data. I think Sri mentioned, you really sort of had encounter-based medicine where you really are just focusing on that few minutes you're spending with the patient, but you really are not able to do anything more on that. And I wanted to, take you to this interesting cartoon we talk about when we talk about data silos, which is, somebody, a provider as well, feels the push to sort of, multitask and take care of all of those things in order to provide the type of care, Sri, that you're talking about for a population like that.
So let us talk about this, right? I mean, I'm just looking at our population or any population for that matter in some sort of a special needs plan. You got, member demographics, enrollment data coming from CMS. We need SDOH data, looking at understanding what's happening in that side. Then we need, which network of providers are taking care of them. So we need that data coming in. Of course, we need the medical data, pharmacy data, claims data, level of utilization, what's happening with that, and what are they authorized for, what are they not authorized for, all of that. And then we got to get clinical data, like from an EMR, talk about bring in how you pull that information in. Then we have to extend ourselves to just our EMR, but other EMRs where the patient get care. So if you got to create a longitudinal care record or a coordination of care, then you need, HIEs, PCC, SNFs, hospitals, EMRs, everything that together. Then, of course, you have to understand costs. So you have to risk adjustment factors. So you need to get that information. Obviously, our membership has got some supplementary benefits and coverage. So we got, catalog vendors and third-party vendors who provide that information. Talk about HCC codes, diagnosis codes, line codes, reference data, and then, take it, which member is calling the call center, what's happening with the provider, that information. And then we have to get cost data. I mean, how much is it costing? What's our cost of the NP or the physician? What is the administration cost associated with it? And then finally, if you want to do something really radical, get genetics data, right? So think about all of this data that has to come together in a way to solve this problem. If you look at all of these coming together and saying, how do we get this information? And that's why you have these tentacles. Because the tentacles are reaching out to different sources, but at the end, you happen to have this octopus brain that is trying to, coagulate this information and making sure that that patient is getting the blood pressure he needs and is still thinking through the process of making sure he's clinically sound, right? This is exactly what's happening in the industry, not just us, but across the board. And any type of SNP model, IE SNP, iSNP, DSNP, CSNP, any model, this is a classic issue. And Gaurav talked about interoperability, and I don't want to bring up that big word because interoperability means a lot of things to a lot of people, right? So when I talk about, bringing data together, and of course, each of them have their own ways of coding it. Each of them have their own, you talk about HL7, FHIR, I bring in data through CCDs. I'm not going to go to the detail, right? That, you can get every alphabet soup out here. But the problem is, we don't think of data as a ways and means to deliver care. We think of data as a ways and means to understand what is happening. The point I'm trying to drive is, we only understand from one perspective. We never have that cost perspective in the model. In many respects, that aspect is missing. For us, as a value-based care entity, that is critical because that will drive definitely improved care, reduction in waste. We avoid people going to the radiology visit every other day because they don't have to be. You could use yesterday's because nothing has changed dramatically with the patient in 2 days because the patient has not moved from the bed. Think about those kinds of things and then look at the cost associated with it and the waste that we can eliminate. That is where we are focused on.
Yeah. Shri, the other part of that is, collecting all this data and getting that view of the complete picture is one piece, right? And then how do you drive the right insights and then deliver it to the clinicians, to the right stakeholders at the right time, right? And, clinicians, as we know, are already burdened, right? And we know there's a shortage, right? And some of these nursing homes that these patients live in, these members live in, are high intensity, high pressure environments, right? And so I think it's on all of us to make sure that, as we're collecting information from all of these different sources, we're not at the same time burdening or inundating clinicians with all of that. Like, we're figuring out what those right insights are and delivering those at the right time to the clinician. So when the patient's in front of them, when a member's in front of a clinician, they know exactly, what's the 30-second view of the patient, what are the 5 things I need to cover off, and how do I do those, right? Rather than, all of the different data and information sources that might be available to them. So the delivery of information is sort of another piece that, I think there's been lots of interesting progress there in terms of algorithms and things that, allow us to do that in a more direct and sort of a right place, right time way.
Yeah,
that is where we look at our data platform, Gaurav, in the sense that we spent quite some time trying to identify how do we populate a data platform, ingest the data in a way that is meaningful to a standardized data model that we can then drive dashboards, reports, analytics for that model of care, right? Because I have to keep that in the back of the mind. And then talk about those chronic conditions that the patients are going through and start looking at, data that is mapped to those chronic conditions through diagnosis codes, HCCs, whatever. That will drive overall improvement. So we spent quite some time in the, analyzing what we need, putting together a kind of a data strategy, a data model that will allow us to define, not for today, but for tomorrow, all of those data elements we need to capture, somehow figure out how to ingest that into something that we can kind of be valuable enough for us to manipulate and then deliver value. That we spent quite some time doing that, and Gaurav, you guys helped us through the process. So I think with the overall understanding of not only breaking down silos, but beyond that. I mean, you can break down silos and get it into one place, but then how do you make it useful? How do you make it easy? How do you make it, because clinicians, they get bewildered with lots of data thrown at them. You have to give them snippets of data that they can choose to evaluate and manipulate. You can't just barge them with data, right? I mean, I've heard this thing a million times. 1,000 clicks, right? Click the clinician with 1,000 clicks, and the clinician will die at the end of the day, right? Because he's not going to do anything. He's just go done, move on. So what is it that we can do? What is it that we can be actionable in small ways so that they can answer ongoing day-to-day clinical review of the patient, of the assessment, bring in that factor and talk about things that they can actually do to improve care. That is what we're doing today. It's not the data barrage in front of you. Here's a report of your 1,000 categories you need to worry about. And the clinician goes, I don't know what to do with it, right? So it's great. I got it. How do I do this? So we really looked at the overlay over the EMR to help the clinician choose what he likes to see or needs to see, give him the option, because clinicians like choice than being put into space and say, this is what we want you to do. No clinician is going to accept that. We know that. So we give them options, we give them choices, we help them figure out what they think they need. In some cases, we might be wrong. That's fine. We learn and we deliver more. But it's been very successful. That capability of us delivering some sort of a notification to them in a way that is not interluding, in a way that is not interfacing with them that is jarring. It's more of a, here, why don't you look at these? Here's what we see the gaps are. Could we close these gaps in the EMR? That's the way we do things.
Yep. Love it, Shrey.
I love that we are sort of ready to move on to two of our favorite topics at Innovaccer, data and technology-enabled workflow. I think, Sri, you talked about the fact that data is not necessarily like how you deliver care, but really use that to drive decision making that should deliver outcomes. So just sort of to bring it all together, I think you talked about your data platform, really coming up with a specific sort of data first strategy as an enterprise. So you're focusing on those outcomes, particularly in light of your model of care. I think I would love to maybe talk about different types of data. How you're leveraging that, particularly things like what I would imagine in your environment is, a real complexity in regards to clinical data from so many clinical data sources, and also using that against claims data that you have that you're getting from, your payer partners, and how is that ultimately being designed in your environment, harnessed for the purposes of business and clinical outcomes?
I mean, today, as I mentioned, right, we get data from various sources.
Mm-hmm.
The data sources, obviously, if you take a simple example, a member ID, right? In one system, member ID is X. In another system, it's called HICN. In another system, it's called MDI ID. In another system, this is called MID. And we are dealing with multiple payers, our own EMR, and then we got dealing with CMS. So we just to map what is a member and what is his ID alone, and each of the systems create their own IDs. Forget about one ID across the board. Each of the systems create their own IDs. So we had to accommodate all of these nuances, which we need to pull together. So we were in our data ingestion engine, our application platform, data application platform, we said we will take the data as it is. We will drive a structured process of building out a model that is adaptable to this specific need. It's a slightly different than typical what you define in the data design model of large health systems, because large health systems, they've got their epics, they can pull the data through Clarity, do radar reporting, Cogito, and so on, and get it done, right? In some respects. But they still struggle with getting data from the outside. So for us, this is even more complex because of the most acuity of our patients. So what we do today is we pull this data, we normalize this data, load this data into our environment, and then drive analytical dashboards from them, because we understand the back-end nuances at the lowest level and are able to pull that together. That is how we create a single source of truth for us, because we want to make sure that there's only one place, because the interpretation is different, right? MMR data gives you a different level of interpretation. Our clinical data from the eligibility file gives you a different level of interpretation. It's a mix. So we drive that single source of truth by forcing all of the data to follow the same process of ingestion and then back-end aggregation into dashboards.
What is your view, Gaurav, on this data strategy conversation?
Very, very complex and interesting topic. We could talk about this all day. The other challenge that we're seeing with a lot of organizations is just the number of systems the data has to jump through, right, before it's actually ready for consumption and reporting, and then you get it back into the hands of providers, right? I take claims data as an example. Like if you think about claims data being submitted by the provider coming to a payer, right? By the time it enters the payer's environment, it's going through some sort of EDI transaction, EDI load, then it's going to a claim system, then it's going to a HEDIS engine. And then from a HEDIS engine, there's some kind of downstream analytic solution that actually generates the quality reports, right? So by the time you look at that, it's gone through 5 or 6 data hops between all of those systems, right? And each of those data hops comes with its own set of, transformations, its own set of loading, certain logic that's built into each of those systems that transforms the data and so on and so forth. So often what we see is you may be getting a lot of data into your environment up front, but by the time it goes through those 5 or 6 data hops and what comes out on the other end, you may have lost a good bit of data or transformed that data into something that may not necessarily be, full, complete, accurate picture of what may be actually happening with the patient. So I think following that true sort of data trail, that audit trail of, okay, are we doing everything correctly to all the data that's coming into our environment, and then generating the right reports and insights, going through all of those 5 or 6 data hops for every single piece of data, I think is really, really important. And some of the largest organizations are struggling with that, right? Because if you think about, and now I'm going to sort of zoom out a little bit, if you think about some of the larger organizations, right, larger payers or larger providers, a lot of those have grown through acquisitions. A lot of them, every single healthcare organization has tons of partners, right, that deliver care, or some component of care, right? To Sri's earlier point, you've got partners on the supplemental benefits front, as an example. And so as you think about all of those systems and the multiple data hops that happen on clinical data or claims data, if you don't have that true audit trail to figure out what's happening with each of those data hops, how is the data being transformed, how is it being massaged, what codes are being dropped, what codes are not being dropped, it's really hard to get a true picture. And then ultimately, at the end of the day, it impacts organizations as well, right? If you're not processing your quality data correctly, it's going to impact your star scores on the other end, right? So
Mhm.
to be able to actually get all of the data and process it in the right way and make sure you're not losing data or, changing it, massaging it in any way that actually, doesn't give you a full complete picture, I think is very, very important and another big challenge for every single organization.
Yeah, absolutely. I couldn't agree more. I mean, one of the things we always hear is, the fact that a payer will struggle with clinical data and then the provider will struggle with claims data, and how essentially combining them together to make sense of any of it, continues to be a persistent issue, but can obviously, if done well, be, a gold mine in regards to what it can do downstream. I think one of the things that we kind of briefly discussed, but in my view is, really, really important is how do you sort of create the workflow efficiency that technology can inherently provide, right? I think, Sri, you mentioned the EMR overlay where you're really discussing the fact that you don't want to overburden the provider with too much, and focus on some of the reduction in administrative burden. And I do think that some of the technology enabled efficiencies can really help with, as you mentioned, Gaurav, the workforce shortage, right? There is the whole AI element that is really coming up as a value driver. There is so many elements of our industry that continue to be sort of manual that inherently can, benefit a lot by a single data platform and just technology that is, flowing that data to the right entities and enabling some of that efficiency. Any thoughts on that, Steve, for you, for your stakeholders at Longevity, and obviously, Gaurav, would love for you to add in
No,
based on your view.
so let's think about this, right? Who is the user of the data? What are they doing with this data? What are we driving? That is, if you answer those three questions, we will have people, many people, build warehouses in the assumption that somebody will need to use the data. We built our EMR based on what the clinicians have to do and what the clinicians want. Two different things, right? So we realized we have a model of care which we filed with CMS. We have to capture, take one of the HEDIS measures, right? Colorectal data submission. There are certain exclusions, certain populations that are impacted. There are different ways to do it, different ways to code it. It's complex, but we have to take the complexity out and do all the backend mapping in the data layer, but allow the physician clinician to figure out what they need to see and close out that, right? So what I see technology to do is to mask the complexity, take the actual output that we are expecting the clinician to do and deliver to them that data snippet that they need in order for them to perform care that day. Don't give me, this patient had high blood pressure 6 months ago. Makes no sense. If somebody had taken their blood pressure yesterday, that's important for me. What they are taking today is important for them. So drive data in a way that you can, don't jar them. Again, don't give them all the data in a report and say, look at it, because nobody's going to look at it. We've seen that clinicians don't do that. Provide them with that information in a way that they can use it. And I said, right, alerts makes no sense if people will just click through the alerts. So the way we do this is we look through the model of care, we drive the assessment. In the assessment, we feed to the clinician, hey, have you looked at this? Hey, have you looked at this? As a way to kind of walk them in their workflow, not outside the workflow, in their workflow, what they need to get done. That is how we removed, all the administrative tasks that they typically do, right? I mean, I got to check this box. I got to check this box. No, you already have the boxes checked because you saw the patient yesterday, day before yesterday, 2 weeks ago, whatever. That capability you bring in and you feed that information in, so you don't keep asking the same question. How many times have I gone to a physician's office and every time I go, they give me this pad that I need to write out and sign? It makes no sense. You already have the information. You provide the information to them. They agree, done. That is the kind of thinking that we are putting in place. what we think we need the clinician to do. And they are part of the feedback mechanism. We have an ongoing relationship with the clinicians, tightly coupled with what we need to do to deliver that value. That's how we do things.
That sounds great. What about you, Gaurav? What do you think?
Yeah, I mean, I think we're seeing some interesting applications of technology, right, in providing better care. I'll maybe give a clinician example and a consumer example as well. On the clinician side, I think it's very easy to see a patient's compliance with a care plan, right? So let's say if a Medicare beneficiary has undergone a knee replacement, right? Part of their care plan is they should be walking 5,000 steps on day 8 after surgery, right? If they have a simple tracker, right, an Apple Watch or a Fitbit on their hand, it would be very easy to see if they walked 5,000 steps on day 8 after surgery or not, right? And if they didn't, it should be very easy for us to be able to say, hey, we saw you didn't walk 5,000 steps today. And if that's the case, one of two things happened. Either they walked the steps, right, and weren't wearing their Fitbit or Apple Watch, because sometimes you forget, or they weren't actually compliant with the care plan and something else was going on. Maybe they had more pain or more swelling or more inflammation, right, at the site of incision. And so if that's the case, that patient needs intervention, right? And so to use technology to drive simple but effective use cases like that, where we're saying, hey, that's a very easy thing to do. If we know their care plan, if there's ways to assess the data against the care plan in real time and say, hey, patient XYZ, you're supposed to do this, but you haven't, so let us check in on you, I think is how we should be thinking about the use of technology and how we're delivering care, right? And then the same thing on the consumer side, right? This is not all up to clinicians. On the consumer side too, I'll throw in another example. If we know a member is supposed to pick up a prescription, right? Let's say they have a chronic condition, they're supposed to pick up a prescription, and we know they're coming up on their refill, right? Can we send a simple text and say, hey, we see you're coming up on your prescription refill. Like, would you like us to send you a link to go pick up your prescription, or would you like us to do a mail order for you and send the prescription to your home or wherever you are? Right? Like, how easy would that be for the patients to just simply say yes back on a text message and say, yes, send me a mail order for my prescription. I have 3 days left, right? And we get the medications to them. And that way, you're reducing barriers for that patient to be able to take their medications to be compliant with the care plan, right? So I think in our industry, there's a fair amount of low-hanging fruit. And I say that with a grain of salt, because I know it's not easy, right? All of the challenges we talked about in terms of data silos and in terms of being able to identify the right insights at the right time do create complications. But I think there's a significant role for technology to play and go after some of this low-hanging fruit that exists in the industry, in the ecosystem.
Yeah, absolutely. One of the things that we often hear about is obviously the compliance side, right? Obviously interoperability, for example, to your point, Sri, is multiple things to different people, but it's also compliance requirements. And I mean, I do think that it is helping us move further along as an industry. However, it also creates, significant challenges as you're wrestling with cost and all of that, but you also have to stay compliant. And, I know that at Innovasa, we're really trying to also, move the compliance needle, so to speak, by just being champions of interoperability and tech-enabled workflow. One of the things that I think I saw that's also one of the questions is how predictive analytics can serve better sort of outcomes. I think as we're talking about AI and generative AI in particular, or AI, the use of AI in healthcare in and of itself, there is the ability to look at all the data and all the trends and just predictively sort of spot where you believe you'll really have to focus on. So I know, Sri, that this is something that we're working with you on, but would love to kind of get your opinion on what are you viewing as the key elements of predictive analytics that you think that an ISNP plan or a population or a plan that catering to a high need population should really focus on, because it is different, right? It's not just readmission risk, which is important, but there's so much more that you need to focus on.
I mean, I go back to the past CEO of Geisinger. He used to say 85 to 90% of healthcare data is outside the healthcare system. We realized that truly in our population. I'll explain to you how. So, a simple example, it happened last week. We have a patient who we know for sure is under our care. We've had several assessments. We know he's a high risk patient, chronic, has got diabetes, asthma, COPD, CHF, all of those things, and it's in the onset of dementia kind of situation. Now, the patient was perfectly fine when our NP went and visited them, no problem. 2 weeks before, the patient started not able to talk as much, was finding difficulty to eat as much. So, and then of course, was trying to get out of bed and they couldn't, and so on and so forth. None of this is documented as codes in an EMR that you can just go pick and go, hey, we got this problem, right? What do we code? We code diagnosis codes. We code ability for them to, take medication or not take medication, basically to MedRec, right? And then we have lab results, we have radiology results. We don't have day-to-day happening of that patient to truly understand the prediction risk of them to get readmission. Guess what happened? 3 days, or I think 4 days before, the member tried to get up. Obviously, he couldn't because he hadn't eaten for 3 days. I mean, somebody didn't document that, obviously. They say, okay, he looks fine based on what they said in terms of conditions and everything else. So you have to look at other things that really impact. The patient fell down. You tried to get up, fell down, had a problem. Guess what? The SNF called the nursing home. So the nursing home called 911, took him to the ER, got admitted, 10 to 15 days admission for the next 3 to 4 weeks. All of a sudden, you didn't have any clue what happened. The patient was fine, 2 weeks, 3rd week, he's in the hospital. Now, if somebody documents the fact that he has not eaten, or he has had problems with waking up, or he's not talking properly, or his eyes seems droopy, that we think we need to take a, those things drive predictive analytics. Those things drive readmission prediction much more than your LACE plus and whatever mechanism you got. You could do all that, right? You could do all that because that's all data. Over the years, people have done research, great, use the data. So what we are looking at is doing something different. Doing things that will help us predict that with non-standard healthcare conditions that we can drive admission reduction. That's where we are trying to do things and doing better on those things.
Yeah, it definitely is such a great example of how, the non-clinical data, as we traditionally talk about, is such a big driver of how you ultimately end up, doing. Any thoughts on you, Gaurav, and then we'll move to questions.
Yeah, I'll probably end with a crazy thought here, right? But my hope is that in 5 to 10 years, we're pushing predictive analytics to a point where we can use a person's genomic data to actually predict their health outcomes throughout their life journey, right? If your genomic makeup looks a certain way, are you more inclined to have heart disease when you turn 55, right? Or you're inclined to have XYZ when you turn 75 and so on. And I know we're not there yet, but I think that's where the industry is headed, and that's where and maybe this is more hopeful than it is reality. But I think that's where we need to be as an industry, right? Is predicting outcomes, and only when we truly do that, right, we predict someone's health outcomes way before they actually manifest, is when we're going to solve the sort of global challenge of affordability and where we started this conversation, right? Until and unless we do that, like, we're going to be in a reactive space, and by the time somebody has had an incident or an episode, it's already too late, and they're a high cost to the system, they're a high cost to the society, and the only way to truly address that is move that way up front. So maybe a bit hopeful and a crazy thought, but I think that's where we should have predictive analytics be in 5 to 10 years.
Yeah, that would be great. I would love to know, because then I'll, tailor my life accordingly.
Exactly.
Awesome. We have quite a few questions. I will go with and bring them up one by one. So there's a question for you, Sri, on how did you mobilize the analytics insights to help your clinicians?
No, it's driven by clinicians. Clinicians drive what they need.
Mhm.
We look at them to understand it. We have their model of care, which we've documented already. We know what will benefit them. And that's what drives our ability to deliver the analytics to them. Very simple.
Mhm. The other question is, what type of data silo challenges can be solved through Gen AI? Any views on that? And it's a question.
Okay, we need a webinar for a Gen AI topic, Carol.
Agreed.
Because it's such a huge topic. I mean, you're talking about a next generation NLP, automatic algorithms that drive data that's coming from several sources that you can automatically evaluate and provide feedback. It's a great topic. Are we there yet today? No. Will we be there? Yes, probably. I don't know. Hopefully in my lifetime. Faster, probably. But I think it's got a lot of promise. My world is a lot of promise. Gaurav?
Yeah, Sri, I go back to the challenge you pointed out earlier on, even something as simple as member ID is labeled and called 7 different things in 7 different systems. I think like even simple problems like that can be solved by Gen AI, right? Gen AI can actually write, SQL scripts for you to pull data and actually do some matching, right? If we need to pull records on a specific member and we know they're, labeled or have different member IDs across 7 systems, then AI could actually pull a longitudinal view for you across 6, 7 different systems by writing simple SQL scripts, honestly, that can pull that data from different systems. So I think there's lots of real applications of Gen AI happening, in even simple things like stitching together data sets across multiple systems. So more to come on some of those applications, and Sri, agree, you probably need a full hour on Gen AI and specific use cases.
Yeah, absolutely. I think somebody mentioned substance abuse disorder and medication refill and medication MAT refill. I think they mean medication adherence. Perhaps, maybe I could be wrong, Mary. So feel free to add more. But any views on that, and any how that is maybe a part of the, I guess, the outcomes or clinical strategy for substance abuse in regards to your population, Sri?
Yeah,
So,
I think that. Sri, go ahead.
It's a big problem. It's a big problem for us. I'll explain why. Our population has got severe behavioral kind of issues. I mean, they are lonely. They are in a secluded environment in many instances. They may or may not see anybody for the whole day in some respects. Maybe 1 or 2 people just passing by doing them. Those kinds of things trigger a very severe behavioral health type issue. And that piece, we've got people who understand that population in our clinicians, right? They understand the population. And we've seen many of our nurses being called daughters by our members. Why? Because they see them more often than their daughters, who comes to visit them once in 2 weeks. But our nurse is there every day, so they feel that nurse is their daughter. Sometimes it's dementia too, because you don't know. But that is how we are, because we bring in music therapy, we bring in companion therapy, we bring in therapy of making sure our nurses sometimes bathe them, help them eat. Very different model, very different mindset. That's how we break into that behavioral kind of model.
Yep. So I know we're on time, but thank you so much for your time today, Sri and Gaurav. Thank you for this engaging conversation. And I wanted to thank all our attendees for joining. Thank you so much for your time, and have a great rest of the week. Bye.
Awesome. Thank you.
Thanks for having us.
Bye.
Thank you.
Bye-bye.